Okay, we're going to start with the exam 2 material. This covers intrapartum, so basically what that means is the time during labor and delivery. We have 3 weeks of class to cover all this material, and your exam will either be June 21st or 22nd for my summer 2023 students. It's going to cover chapters 8 through 12 in our F.A. Davis book. All right, so what are some things that cause labor to start or trigger it to start? There's actually some mom things and some fetal things that can occur in the body that will cause labor to start. So when you're looking at maternal, we have the uterine muscle stretching. So remember, your uterus is a muscle and it can only grow or stretch to be so large. Once it hits that maximum threshold, it's going to start contracting and cause labor to occur. Other things that happen is some pressure on the cervix, so that fetal head drops down in the pelvis, causes some pressure to occur on that cervix, causing it to dilate, kind of efface, get a little bit thinner, causing labor to occur. There's an increase in the estrogen levels, and then also a decrease in progesterone. And remember with progesterone that for preterm labor or even our spontaneous abortion, our patients that have a history of that, we would start them on progesterone supplements during their pregnancy to decrease their risk of delivering early. That was due to they would have lower amounts of progesterone, which would put them into labor. So we try to increase that progesterone to keep them pregnant. Well, now once you get close to your due date, your body naturally decreases your progesterone, putting you into labor. Other things that occur for the fetal side of it is there's some prostaglandin synthesis, there's changes in the fetal cortisol levels, and this all causes contractions to occur. Signs that labor is about to happen or impending signs of labor include the following: lightning. So that's when the fetal head drops down into the pelvis. You'll see a picture of that on the bottom there. When that occurs, the patients are able to breathe easier because that fetus isn't so high up in their uterus, isn't pushing up on their diaphragm, but they do need to void more because now that fetus has dropped lower where it's pushing down on that bladder. These patients can experience Braxton Hicks contractions. A good way to think of this is like false labor contractions. They're more of an annoyance. They are little contractions, but they don't cause any cervical change or anything like that. The cervix itself will start to soften, possibly dilate a little bit just from that fetal head pushing down on it. The patients can lose their mucus plug. There's a lovely picture of that I included for you right there. This mucus plug is it accumulates inside the cervix to kind of help as an extra barrier to keep any bacteria or infections from reaching that fetus. Some women will come in and say, "Oh my gosh, I lost my mucus plug, I'm in labor." No, you're not in labor. It's just something that kind of falls out once your cervix starts to dilate just a little bit. They can have a change in their vaginal discharge. Another thing they can experience is what's called nesting, and that's a sudden burst of energy. This is where you'll hear of pregnant women like on their hands and knees scrubbing the floor or cleaning the entire house, washing all their linen, stuff like that. It's to prepare for the birth of the baby. They could have a weight loss. Usually it's about 1 to 3 pounds. This is due to some nausea and vomiting that can occur, and also some diarrhea. It's the body's natural way of getting rid of any fecal matter that might be in the way from helping that baby descend through the birth canal. They can have a low backache, and then, like I said, the breathing easier and voiding more. So now we're going to switch into what are called the 5 P's of labor. So these are 5 different factors that are each important and an essential part of being able to have a successful vaginal delivery. So we've got the passenger, which consists of the fetus and the placenta, the passageway, which is the birth canal, the position, which means the position of the mother, powers, which is contractions, and then psychology or the emotional response. So we're going to talk about each of these a little bit more in depth. Let's start with powers. So this is the contractions. So we have what we consider primary powers, which is your involuntary. These are your contractions. Like you can't tell a contraction to come and go. It just happens. It's involuntary. And then your secondary or your voluntary actions is pushing. So when we get to the second stage of labor, when it's time for the mom to push, that's also considered part of the powers. Because you can get to complete and have a horrible pushing patient, which could impede her ability to deliver vaginally. Therefore, that powers, that P, that essential P, is affected, and she might not be able to have a vaginal delivery. So back to our contractions. So when a contraction starts, it's going to start up at the fundus, the top part of the uterus, and that's where it's going to be the strongest, and it's going to push that baby down lower to the lower uterine segment. Contractions are what are responsible for dilating and effacing that cervix. They're rhythmic, they're intermittent, so it's not one constant contraction, they come and go. During a contraction, the blood supply and oxygenation to the fetus is reduced or completely cut off, and also the CO2 from the baby to mom, that's not exchanged during that time either. So it's very important that there's enough time in between contractions for the baby to be able to get that blood and oxygenation it needs, and also to get rid of any of that waste or CO2 that it had accumulated. So that time between contractions is called the resting phase or the resting time. And we'll talk more about this when we're looking at contractions a little bit later on. When a patient is ready to push, what happens, and when she feels that intense urge to push, that means that the Ferguson reflex has been activated. So the Ferguson reflex is activated once that fetal head is down to about a +1, +2 station, which we'll talk about here soon. And that's where the mom will feel like, oh my gosh, I need to push. That's all because of that fetal head pushing down on that part. Okay. You'll also see listed on here the another P, the psychology, the emotional response. So things to consider with this is, what's mom's social support like? Does she have social support? What are her past experiences like? Has she gone through labor before and maybe it was a really horrible experience? So she might fear that and have a little bit of anxiety with this delivery. And what's her knowledge? Like, what is she expecting or know how labor and delivery should go? So as a nurse, you really want to try and get her anxiety level down and her pain to help that contribute to a successful vaginal delivery. Okay, the next one is our passageway, the birth canal here. So this consists of the pelvis, the cervix, the pelvic floor, the vagina, and the introitus. There's 4 different types of pelvis listed on here. We have the gynecoid, android, anthropoid, and palatoploid. Try saying that 5 times fast. Palatoploid, palatoploid. Okay, it's kind of hard. Anyways, there are 4 different types. The most common and the best one to have a successful vaginal delivery is your gynecoid. Okay, how are you going to remember that? Well, gynecoid sounds like gynecologist. Okay, starts the same. Females go to gynecologist for their lady parts. Okay. Palatoploid, that one's the least common, and it's pretty hard to have a successful vaginal delivery with the palatoploid. So how do we tell what type of pelvis a patient has? This is something the provider can kind of tell, and it's kind of difficult as a nurse for us to figure this out, but the provider can tell them that. And then you'll see the other soft tissues listed on there too. Okay, passenger is our next one. This kind of consists of a lot of different things, a lot of different ways that the fetus can affect a successful vaginal delivery. First of all, we have the size of the fetal head. This is the largest part to come through the birth canal. Okay, the fetal head is made with so that it can mold, and what that means is that it can kind of change its shape to fit through the vaginal canal. When you look at a fetal skull, you'll see that it has suture lines and fontanelles. These suture lines allow the bony prominences, the bones, to be able to shift around, and they can even overlap each other to help that fetus fit through the birth canal. The other thing to notice with the fetal head is the fontanelles. So we have the anterior fontanelle and the posterior fontanelle. The anterior one is up front, anterior front, posterior back. The anterior one is diamond shaped. It's bigger. Okay, it's a little bit easier to feel. And the posterior one is triangle shape. It's a little bit smaller and it can be a little bit difficult to feel. But when you're doing a sterile vaginal exam on a mom, this is something you should be feeling for, is where are these fontanelles? And we'll talk about that in a few slides here of why we need to know where their fontanelles are. The next thing on here is the fetal lie. This is looking at, it's in relationship to the spine of the fetus related to the spine of the mother. So basically are both spines going up and down, okay, vertical? If so, we can say we have the fetus is longitudinal, or we can say vertical. If it's going sideways like a T, so the baby's spine is going left to right and mom's is going up to down, then we either call it transverse, horizontal, or oblique. A transverse baby cannot be born vaginally. Okay, we cannot fold that baby in half to get it to fit and come out through the vaginal canal. Okay, the next thing listed on here is our fetal presentation. So presentation means what part of the fetus that is going to enter the pelvis first. So cephalic would mean head first. Great, that's what we want. Okay. We have breech as another one. So this would be either their butt, or they could be a footling breech, which means their feet are the things presenting first, or a shoulder. So the shoulder is a little bit more common when you have a transverse lie, when they're lying sideways. Okay, this slide also goes along with the fetal presentation. Things that you want to look at is what's called your fetal attitude. This is the relationship of fetal parts to one another. So ideally, with a vertex position, with our head being down, the fetal chin is flexed and touching the fetal chest. So that's your first one. Now, as you look through the rest of these three pictures, you'll see with each picture that fetal chin kind of extends out a little bit more, where you're to a full extension on the last one, and we now have a face presentation. So you will notice here that the part that's going to be coming out of the vagina first is going to be their, eyes, mouth, and nose. This is a very difficult vaginal delivery and very high risk, just because it can lead to a lot of nerve damage on the fetus and a lot of complications. So ideally, they would not leave the baby in this position. They would try to get it to reposition to the correct way before attempting this vaginal delivery. Over on the right, another thing with the fetal position is what we call the fetal station. So the station is what the presenting part, okay, so our head or whatever the first part that is up on the cervix, is located in mom's pelvis. So you'll see that there's a picture of a pelvis here with some green lines on it. What these green lines represent are positive stations or negative stations. And you'll notice that The way bottom of the green line says +5. Okay, that would be where if you pull the sheets back on mom and you look at her perineum, you're going to see crowning. So baby's head is going to be visual. You're able to visualize baby's head. That's a +5 station. And then as the baby's head goes up farther in the vagina, we go then +4, +3, +2, +1, and then we're at 0 station. 0 station is right when baby's head is at the ischial spines. And we'll bring the pelvis into class for you guys to be able to see what the ischial spines are. And then if the fetal head or the presenting part is higher than those ischial spines, then you're at minus. So -1, -2, -3, -4, -5. Okay. Again, we'll kind of explain that a little bit better in class. A few slides ago, I was talking to you about feeling to see where those fontanelles were. And this is why you need to know where the fontanelles are, because this is going to help determine what position your fetus is coming down in the birth canal. Ideally, your baby is going to be either in one of the top two, the ROA or LOA or just OA. So let's look at these, what these letters mean. So ROA, right occiput anterior. So when you are doing a vaginal exam on mom, what this means is that the occiput, so you're going to feel that posterior fontanelle, okay, that is going to be to mom's front, mom's anterior, and then it's also going to be on mom's right side. So this baby is ROA. ROA and LOA are the best ways for these babies to fit correctly through the vaginal canal. The other ways, the ROT and LOT, your baby is in there sideways, and then your ROP and LOP, or just OP, occiput, is posterior. That means baby is, if mom's laying in bed on her back, that means baby is laying in there looking up at the ceiling. Can deliver vaginally this way, but usually they have to push a lot longer, and it can cause a lot more lacerations and tears and everything. Our next P, the last one we have, is position. And this is all in relationship to the different positioning or positions that mom is in throughout labor and with delivery. So we already know that mom should never be in the supine position. We've talked about this for exam 1. We always want her at least tilted, or left lateral or right lateral are good positions. But there is also lots of other positions that these moms can go in. And there's pictures here of walking, standing, leaning, kneeling, sitting, squatting. What they found is that frequent position changes can decrease the length of the first stage of labor. When it is time to push, so mom is complete and it's time to push, some upright or lateral positions are the best to help get that baby to deliver. And remember to avoid those supine positions. All right, let's talk about true and false labor. So how do you know if a patient's really in true labor or if they're not? So let's talk about true labor first. So these contractions are usually very painful and they're difficult to talk during one. So if the patient's having a contraction, she's going to have to stop, think about it, kind of breathe, really focus on her pain and the contraction. These contractions in true labor have a pattern and they'll become closer together with time, to every about 2 to 3 minutes. And there's dilation of the cervix. There must be cervical change. And no matter what you do, so if you, do different positions, if you walk, if you hydrate, anything like that, take a rest, it's going to continue. It will not, true labor will not stop with interventions like that. Now, false labor, Braxton Hicks, which I had mentioned before, these are kind of more of an annoyance. Like you're like, oh, I feel this contraction. Usually they're not as painful. You're able to talk through them. There's not a specific pattern, like maybe for an hour you'll have them every, 5-10 minutes, but then they go more like 15 minutes apart. They don't increase in intensity and closeness together. There's no cervical change. And these Braxton Hicks, a lot of times if you hydrate yourself, empty your bladder, rest, do some different position changes, they can stop, whereas true labor, it would not stop. This is a little review. We'll talk about this in Skills Lab next week, but rupture of membranes, or ROM, so not range of motion, but rupture of membranes. So there's 4 different tests that we can do to see if a patient's water has broke, and it's going to depend on where you work at to see which tests they do. So the first one is a speculum. So you'll see that lovely, I call it a duckbill. What they do is they can place that speculum in mom's vagina, and they can visualize to see if any fluid is leaking out of the cervix. The next one listed is ferning. Think of a fern, it's a plant, right? So amniotic fluid, what you do if you're going to do a ferning is you're going to collect some amniotic fluid. So you take a Q-tip, collect some of the fluid, you put it on one of those little glass microscopic slides and put it under a microscope. When amniotic fluid dries, it crystallizes and it forms a ferning pattern. So that's what that picture is on the right there. So you're going to look under the microscope and see if you see any plant-like features. Nitrazine, that's a little piece of, it's like litmus paper. You're going to apply some amniotic fluid to it and see what color the paper turns. Amniotic fluid has a different pH level than normal vaginal discharge or urine. Amniotic fluid will turn it a dark blue, whereas urine or vaginal discharge will turn that, it's more acidic, it'll turn it yellow. And then AmniSure is a test that can be done. A Q-tip goes in the vagina, collects some of the fluid, goes into a solution for a minute, and then you take like 5 drops and you see if you have 1 line or 2 line, kind of like a COVID test in a way. And it will tell you either yes or no if their water's broke. Okay, this next one here is cardinal movements of labor. I have a video listed in here. There's also one listed in the announcements. I encourage you to watch the video and be familiar with these 7 different movements that fetuses go through during the labor process as they're delivered. It's really interesting. It's really neat. When you're at clinical, if you're watching a delivery, a lot of these you can see, like the internal rotation, extension, external rotation, and expulsion. You can visualize that a lot of times. But you're going to want to know the order that these happen and what each of them means. Or like when I say engagement, what does that mean? Well, that means that the fetal head drops down a little bit and pushes on that cervix. Descent, the fetal head drops more into the vaginal canal. Flexion, that it gets the correct attitude that we want, that chin flexes down to the chest. Internal rotate, it rotates underneath the pelvic bone. Extension, the head extends to be delivered. Internal rotation, the shoulders and the body rotate to fit under the pelvic bone, and then expulsion, everything comes out. There's a little saying to remember kind of the order of these. Every darn fool in Egypt eats raw eggs. So every is engagement, darn, fool is descent, flexion. In Egypt is internal rotation and extension. Eats raw is external rotation, and eggs is expulsion. All right. Okay, time to start talking about labor. So labor is divided into 4 different stages. And if that wasn't difficult enough to remember, of course they have to have some smaller little stages. Or phases within the stages. So stage 1 is when you go from 0 centimeters up to complete. Stage 2 is once you're complete to once you deliver that baby. Then stage 3 happens, so from after the birth of the baby until you deliver the placenta. And stage 4 is the immediate kind of postpartum recovery phase. So let's talk about each a little bit. So stage 1, this is the one where it's split up into 2 different phases. The latent phase. This is from 0 to 5 centimeters. It's also known as the early phase of labor. During this time, your contractions, they kind of start off a little bit irregular, but they get stronger and closer together and more regular. This is a great time to provide patient education, as these patients are usually really excited, they're eager, they're not in too much pain yet, so they can kind of focus on what you're teaching them. And this is a great time to use some non-pharmacological pain relief. We'll talk about that here in a few slides. Again, longest phase of that one. Okay, active phase. This, once they hit 6 centimeters, they're now in the active phase of labor. You can expect about 1.2 to 1.5 centimeters per hour once they get here. So if you think of that, it should last, what, 3-ish to 4-ish hours or so. Maybe not quite that long, but it doesn't take that long. During this time, the pain increases. This is where they're going to probably want some pain medications if they're thinking that they need to stop and focus internally on themselves. They can also have decreased energy and fatigue, get a little grouchy when they're close to complete. We used to call it the transition phase, but they got rid of that now. But they can shake, they can kind of lose control, like, I can't do this anymore, why'd you do this to me? So it's really, if they're doing it without pain meds, you need to help them keep control of what's going on. So things that we do as nurses for patients in labor, we're going to monitor their vital signs and a pain assessment. We're going to do monitoring the fetal heart rate and contractions, check their cervix, keep an eye on the fetal position and descent, provide support and education, document. We're going to make sure that we have reviewed the prenatal chart to see if we have any, notice any issues with the pregnancy at all, and then an IV is placed. So I talked about non-pharmacological pain management. Here are some examples. So different breathing exercises, really getting the mom to focus on her breathing and not hold her breath or hyperventilate. The next thing is massage or effleurage. There's a picture of it, that pink belly. Basically, you massage in a circular motion, either on the belly, you can do it on the thighs, anywhere like that. It's supposed to help with the pain. You can do counter pressure. That's the bottom right picture. So you're pushing back on the lower back to help. A lot of times if the baby's in there in the wrong way, like if we have the ROP or LOP position, they can have really bad lower back pain, and putting some pressure back there can help relieve that pain. Hydrotherapy, so in the water, warm or cold packs, guided imagery, acupuncture, acupressure, different positioning, aromatherapy, just continuously being there with them, talking to them. Music's another one. Once they request pain medication, we have a couple different options. Fentanyl or other opioids like morphine, Dilaudid, depending on, again, where you work, what their preference is going to be. The thing with opioids is that it does cross the placenta, and if that baby were to be born after giving that medication, so usually within like 1 to 2 hours after receiving that medication, it can cause respiratory issues, okay? Because since it crosses the placenta, how it makes mom feel, it's relaxed, calm. It's also what it does to baby. So we need to make sure she's not too, she's not like 9 centimeters where she's going to deliver soon before we give that. Nitrous oxide is something, laughing gas. You guys might have had it like at the dentist. This isn't going to take all their pain away, but it can help them kind of be better in control. There are some side effects of nausea, vomiting, dizziness, drowsiness. Some women like it, some women hate it. It is an instantaneous effect. The patient can have control if it's delivered via like an oxygen mask. She puts it on, breathes in, gets the relief. She can take it off when the contraction's done. Local medications, this is used more before if she needs to have an episiotomy cut, lidocaine, and place it locally where they're going to do the cut. Regional, there's a couple different things. We have a pudendal block, which I'll show you a picture of here next. An epidural, we're going to watch this video in class. And then a spinal, which can be used during a C-section. Kind of works like an epidural. Next slide will tell you that too. And then the last one is a general. So if we need to put the mom to sleep, like during a C-section, that's called general anesthetic. Okay, so the picture on the left here is showing you the different places in the back where either an epidural would be placed or the spinal anesthesia. You'll see it's very close, but not quite the same spot. Before you give any pain medication to a patient, you need to monitor her or get some baseline vital signs and also see what your fetal heart tones are. During an epidural placement, you as the nurse, a couple things that need to happen is we need to give an IV bolus beforehand because a common side effect of an epidural is that her blood pressure can drop. So we give her fluid beforehand to help hopefully counteract that from happening. During the epidural placement, you are there helping position her correctly, keep her calm. You are monitoring fetal heart tones, mom vital signs, doing some recording. Then you're going to lay her down and continue to watch her vital signs and baby's heartbeat. If mom's blood pressure does drop, make sure you don't have her lying flat on her back. You can give her some more fluid bolus, and then we can give a medication. Usually it's ephedrine or norepinephrine is another one to help bring that blood pressure up. The other picture you see here is of a pudendal. So with the pudendal, this is taking a very long needle and going up through the vagina, and it's injecting medication into the pudendal nerve. This doesn't take away contraction pain, but it takes away perineal pain. So I've seen this done just one time, and it was actually after delivery. Mom had a really bad tear, and instead of going to the OR and getting put to sleep, they did this pudendal block, and they were able to do the repair right in her room. But you can do this when they're pregnant. Just that fetal head can't be descended too low. So you're not going to be at like a +3, +4 station because it's going to be in the way of the doctor being able to reach the nerve. Okay, the second stage of labor occurs once you're complete, so 10 centimeters until the delivery of the baby. So this is the pushing stage. This can be broken down into a latent and active pushing. Latent phase occurs when mom's complete, but maybe she has an epidural and she's comfortable and she's not really feeling an urge to push. If that's the case and baby looks okay, we can let her labor down. So let her contractions and her body do a little bit more of the work to push that baby lower until it activates that Ferguson reflex. Then mom's going to get the urge to push, and then we enter the active pushing phase where she's actually pushing. There's a couple different ways to push. We have an open glottis and a closed glottis. This is just related to if she's letting air out as she pushes. So for example, open glottis pushing means I'm going to take a deep breath in and I'm going to push and let air out. So it sounds like this. Okay, I'm letting that air out as I'm pushing. A closed glottis means I take a deep breath in and I hold all that air in, like I'm going underwater and plugging my nose and not letting any air out. So it sounds like this. See how you didn't hear me say anything after I was pushing? It's because I was letting no air out. The other two listed on here is directed and non-directed. So if you need to direct mom how to push, maybe she doesn't know, or her epidural is really good and she doesn't quite know if she's pushing correctly, then you want to direct her how to push. And the best way to push is to tell her to take a deep breath in, push for 6 to 8 seconds with that open glottis push, okay? Exhale, take another deep breath in, do that 3 to 4 times per contraction. So push for 6 to 8 seconds, let all your air out, take another deep breath in, push for 6 to 8 seconds. Again, do those pushes 3 to 4 times. Non-directed, again, they're going to just push how their body tells them to push. So you'll see this a lot in patients with no pain meds. They just kind of push however, and it works just great. Women can complain of a burning sensation or that burning ring of fire. That occurs as that tissue, the perineal tissue, is stretching, getting ready for a delivery of birth. The contractions during this time get intense and they're greater frequency, and bloody show increases. Bloody show is just vaginal discharge from the cervix dilating. Sometimes it's very vascular. The vagina itself is very vascular, so sometimes those can rupture, or a little bit of trauma can cause a little bit of some vaginal bleeding. Delivers, we're now entering the 3rd stage of labor. So this is after the delivery of the fetus up until the delivery of the placenta. This can take up to 20, 30 minutes, but by that time we want to have the placenta delivered. Signs that you know that the placenta is about to deliver is the uterus is going to rise up into kind of like a ball shape. The umbilical cord is going to lengthen, so the cord that's clamped and hanging out of mom's vagina. And you're going to see a sudden gush of blood. Those are all signs that the placenta have detached from the uterine wall and it's ready to be expelled. They should never apply forceful traction on that umbilical cord to get the placenta to detach, because that can cause it to come out in pieces, and then we're having a lot of issues. There is a medication that should be given to all women during this phase of labor. That's our oxytocin. So this is going to help that uterus clamp down like we want to. We give oxytocin during labor to stimulate contractions. So now we're going to give a whole bunch of that oxytocin to stimulate a contraction to get that uterus to contract all the way down and get little. Other medications that we can give if we need to help get that uterus to clamp down even more is methylgonovine, carbapenem, tromethamine, misoprostol, and tranexamic acid. And we'll talk about those medications more in our postpartum module when we talk about hemorrhages. Just a picture of the placenta that I wanted to show you guys. So there's 2 different sides of the placenta. We've got the Schultz and the Duncan. Okay, a way to remember this is the dirty Duncan and the shiny Schultz. So you'll notice that the picture on the right looks really kind of meaty, beefy, right? That's your dirty Duncan. This is a side that is implanted onto the uterus. The other side on your left, the shiny Schultz, that is, and you'll see the umbilical cord coming out of there, that's the side of the placenta that is right by the fetus. Okay, and you can kind of see the white bag of water, the amniotic sac, is around the outside of the whole uterus. That's the amniotic sac, or the bag of water. To delivers, now we enter the 4th stage of labor. This is your immediate recovery time, your postpartum, usually the first few hours as mom stabilizes. During this stage of labor, things that are important to do is monitor mom's vital signs and her bleeding. We want to make sure that we have vasoconstriction occur to stop that bleeding. So vasoconstriction to the placenta and everything like that. We want to measure how much blood loss mom has had. So you can hear this as QBL or EBL. Best practice is to figure out the QBL, the quantitative blood loss, the actual amount of blood loss. So this is done by measuring the blood that has been lost, either in a bag that has, like 100, 200 mils, 300 mils, or weighing the chucks to get an actual number. Whereas EBL is just an estimate, it's estimated blood loss. You look at some blood on the chucks and you say, oh, that's 150, grams. The other thing that occurs during this stage of labor is the golden hour. This is the first 60 minutes of that fetal life. And it's recommended to keep that baby as long as it's stable, skin to skin on mom. That helps with early breastfeeding. It helps reduce neonatal hypoglycemia. It helps the baby regulate its temperature, and it can decrease the stress on mom and baby. So these are things that should all be encouraged to occur. During the fourth stage of labor, they're also going to repair any lacerations or episiotomies that occurred. The difference between the two, an episiotomy is a cut made by the provider. It's pretty old school practice, but reasons you might see it done is if we need to get that baby out now, or also like get the baby out because there's heart tone issues, or we need to apply the forceps or the vacuum or something like that. And also for shoulder dystocia, they may cut an episiotomy so that the provider has better or more room to help do some maneuvers. Lacerations is the natural tearing of the perineum. You'll see there's different types. There's first degree, second, third, and fourth degree. They get progressively worse as you get higher there. So first degree is just the skin. Fourth degree, the vagina tears the skin and muscle and everything all the way through to the rectum. Here, this is something we're going to talk more about in the newborn time, but it is listed in these chapters, so I just want to touch base on it. So APGAR stands for appearance, pulse, grimace, activity, and respiration. So you score the newborn at 1 minute of life for each of these categories, and then again at 5. And it kind of tells you a general overall well-being of how the newborn is. But if you can answer yes to these 3 questions, is the baby term, is it crying or breathing, and is there good muscle tone? If you can answer yes to those, then your baby should be stable and could be left on mom's chest doing skin to skin for that golden hour. That was all of chapter 8. So let's move into chapter 9 here, and this is all on fetal heart monitoring. So let's jump right in here. So there's a couple of different ways we can monitor fetal heart tones. The first one is auscultation, or you might hear it as intermittent auscultation. This is where you use a fetoscope or a Doppler. A fetoscope they're kind of funny looking. It's like a stethoscope you wear, but it has to like touch your forehead as you lean over and touch mom's belly. It's really weird. Or the Doppler, the handheld Doppler. You can use this during labor. These patients should be very low risk, no issues or anything with their pregnancy, not getting any medications. The reason for that is why they're supposed to be low risk is because it can't tell you everything about your baby, okay? And it's not a continuous tracing of your baby. So you're only going to know what's going on once you place that fetoscope or Doppler on mom's belly. There's no paper trail or paper record. It's all about interpreting exactly at the time you do it. So what this can tell you about a baby is you can get like a baseline of what its heart rate is, which in normal is 110 to 160. You can hear if the heart rate is regular or irregular. You can hear if there's increases in the heart rate from the normal baseline, and you can hear if there's decreases. What you hope that you don't hear any of those decreases. If anything comes back abnormal while you're auscultating them, you should hook the patient up and perform an NST, just so you can see what's going on. Also with auscultation, you want to make sure you're listening between contractions, during, and immediately after to see if you hear any decelerations. And then you also want to make sure that you are feeling mom's radial pulse at the same time, so you can make sure that you're not picking up mom's heart tone with the Doppler instead of the fetus's. And then for contractions, you're going to have to palpate to see when they're occurring. So put your hands on her belly, and when she's having a contraction, her uterus is going to firm up. So it's either going to be mild, moderate, or strong. So mild contraction feels like your nose. You can push her abdomen in like your nose. Moderate's your chin, and strong is your forehead. And then you also want to palpate to make sure that it's soft in between contractions, that resting tone. Do any monitoring of our fetus, we should do Leopold's maneuver just so that we can verify fetal position, and we'll also be able to figure out where the heart tones should go or where we should be picking them up. So we practice this in lab. Remember, there's 4 movements, and then your fetal heart tones are best picked up between the scapula of the babies. Talked about intermittent monitoring. Now, external monitoring. This is what we're used to, what we've talked about in Skills Lab. So we do the Leopold's. We hook up the TOCO, which monitors our contractions. It can tell us how often they're occurring, how long they're occurring. It's not going to tell us how strong they are, though. We need to get our hands on her belly. Remember, that goes up on top by the fundus, on top of the uterus. And then we put the EFM or the fetal monitoring down on the lower part, hopefully, if we're head down. And this is a continuous tracing. There is paper trail for it, and this will tell us our baseline, our variability, our accelerations, and our decelerations. And we'll get into all of that here in a few slides. We might have issues keeping a continuous tracing going of our fetus. This could be due to maybe mom's has a higher BMI. Maybe she's really active and moving all around, and we got to keep going in there and switching, repositioning the monitors. Maybe our heart rate's kind of going in and out and we're having issues with it, so we want to get a real accurate tracing of our fetus. If that's the case, we can do some internal monitoring. So internal monitoring, we have one that is placed internally to monitor baby's heart rate, and one internally to measure contractions. So the first one is the FSC, the fetal scalp electrode. So this is placed, it's a little wire, we'll show you it in class, that gets placed under the scalp, under baby's scalp, and it's going to tell us exactly what baby's heart rate is. Contraindications of people who we could not place a fetal scalp in is if it's an abnormal presentation. So let's say this is a face presentation, okay? The face is coming out first. So we don't want to screw a wire into an eyeball or anything like that. So we have to make sure we have proper presentation. If there's a placenta previa, well, no, we can't place that because nothing goes in the vagina. If mom has an active genital herpes outbreak, if she's HIV positive or GBS positive. The other one is called an IUPC. This stands for an intrauterine pressure catheter. So intrauterine, it's within the uterus, and it's a catheter in there that's measuring the pressure, the change of pressure. To place both of these, she must have her water broke, and she has to be about 2 centimeters so that you can get the wires through the cervix. When a patient has an IUPC placed for contractions, it will tell us how often she's having it, how long they're lasting, but now it can tell us exactly how strong those contractions are. And this is something called Montevideo units. Montevideo units or MVUs, we will talk more about this in class. It's hard to explain, but what's considered adequate contractions is if your NVUs are greater than 200. That's what you're looking for. If so, they can say, yep, those contractions are strong enough. She should be making some cervical change. In order to truly understand fetal heart tones and what their tracings mean, you need to have a little understanding of different things that can influence the heart rate of a fetus. So I want to take a little bit of time to talk about this, and we'll talk about it in class too. But in order for the fetal heart rates to be able to get enough oxygen and to remove its CO2, it needs to have an effective transfer. So be able to get the nutrients in and the waste out. This can be affected by the blood flow that goes to the uterus. So we need to have adequate uterine blood flow. Think of some things that could cause inadequate uterine blood flow. Okay, we've got smoking, we got hypertension, maybe diabetes could, some medications, some drugs. Think of mom has low blood pressure, hypotension, so she's laying supine. Stuff like that all can affect how much blood flow is going to that uterus. The next one is we need to have sufficient placental area. So sometimes placentas are really small, okay? That could affect how much oxygen and CO2 are transferred between mom and baby. Maybe that placenta attached as a previa, and now that where the cervix is, we're not getting sufficient blood supply, or that uterus, that part isn't working correctly. Another thing we need to look at is the umbilical cord. So you want it to be unconstricted. Well, is baby laying on it? Is there a knot in the cord or something like that that can constrict how much blood flow goes from baby to mom? Other things that can affect the fetal oxygenation is what's mom's oxygen level? Do we have, again, enough blood flow to the placenta? And is there adequate circulation between that placenta and the uterus? Adequate umbilical circulation? And what's the fetus's ability to regulate the fetal heart rate? So preterm babies cannot regulate, they don't have their sympathetic and parasympathetic nervous systems are not well developed yet, and they can't regulate their heart rate as well as a term baby can. So you might notice that if you're at clinical and you see like a 26-weeker come in, their heart rate, usually it's a little faster, their baseline, and it's going to be flatter, okay? So if you were to see that in a 26-weeker, it's expected, even though it's kind of abnormal, it's expected for that gestation. Where if you were to see that on a term baby, you're like, wait, why is our heart rate so high? Why do we not have great variability? What we want to do when we're looking at heart tones is we need to figure out what the baseline is. The baseline is your average fetal heart rate. You're going to look at 10 minutes worth of your tracing, and you're going to figure out what the average is. Now, when you're looking at your baseline, you cannot count what we call accelerations and decelerations, which we will explain here shortly. And it needs to be recorded in increments of 5. So 150, 155, 160. Your normal baseline rate is 110 to 160. If you're above that, you are considered tachycardic, and below that is bradycardic. So here's what a tachycardic heart tone would look like. You see your baseline is above that 160. And tachycardia, it can be due to a couple of things, fever or infection in mom. So if you start noticing your baseline going up above 160, check mom's temperature. She probably has a temp. If not, I bet she develops one very shortly. It can be due to dehydration, anxiety, anemia, some medications like ephedrine, terbutaline can all cause the heart rate to go up, cocaine, also activity and stimulation. So maybe your baby's just really active and it's causing its heart rate to go up. Your bradycardia, so your heart rate is below that normal baseline of 110 to 160. This can be due to mom's positioning, dehydration, hypotension, seizures, cardiac arrest, maybe the uterus ruptured, or she has a placental abruption, the umbilical cord is occluded, or some chronic fetal head compression. Once we figure out our baseline, then the next thing we can look at is if there's accelerations present. We kind of talked about accelerations in our first exam with reactive versus non-reactive. Now we can actually kind of talk about what they mean. So an acceleration means that that fetal heart rate goes above that baseline, at least 15 beats above it, and it takes 15 seconds for it to get back to its baseline. So think of it as 15 by 15. If you see accelerations, that's great. This is a reactive strip. We have a well-oxygenated fetus. It's a great sign. We're happy with that. We have our fetal baseline. We looked for accels. Now I want you to look at contractions. And with contractions, you're going to look at the frequency and duration. So the frequency is how often are they occurring. You can measure this a couple different ways. The first way is you can count how many minutes from the start of one contraction until the start of the next. Okay, so you can say she's contracting every 3 minutes. Or you can take a 10-minute strip and count how many contractions are in it, and you can say she's contracting 3 and 10. So 3 contractions in 10 minutes. Normal contraction pattern is to have 5 or less in a 10-minute increment. Duration is how long the duration of a contraction, how long is it lasting? So you're going to count up, you're going to pick a contraction and you're going to count how long that contraction lasts for, of the same contraction. Intensity, again, you need to palpate for it, or if she has an IUPCN, you can see how strong they are. And then the resting tone is that time of relaxation. So the time between contractions. And again, this should feel soft when you're feeling that. So normal contractions is 5 or less than 10 minutes. What happens if you have more than that? Well, that's defined as tachysystole. So there's a couple different ways to define tachysystole, or things that are considered tachysystole. First of all, if you have 6 or more contractions in 10 minutes, that's tachysystole. If your contractions last longer than 2 minutes, okay, so if their duration is longer than 2 minutes, that's tachysystole. If you have less than 1 minute in between your contractions, so your resting time, that's tachysystole. And the last thing is if she has an intrauterine pressure catheter in it, and that resting tone increases, or the MVUs that you calculate are greater than 400, that's tachysystole. So 4 different definitions. Make sure you can identify all 4 of those. So what are we going to do if we notice tachysystole? Well, change positions. Stop any medications she's on that could be causing contractions. So your oxytocin, some of your induction medications. Give her a fluid bolus. Reduce her pain and anxiety. There's a medication, terbutaline. Oh, this is one of our tocolytics for preterm labor. We can give that to relax that uterus, and then notify the provider of what's going on. Here are some different examples. The top one here, it's a normal contraction pattern, and then the other 3 would be tachysystole. See if you can figure out which one of the 4 definitions of tachysystole each of them are. All right, so we've looked at our contractions. Now we can go back and look at our fetal heart rate again. Now we're going to look at decelerations. There's 4 different types of decelerations. This first one is a prolonged decel. This is where the heart tone goes down by at least 15 beats per minute, so below your baseline, 15 below, and it lasts between 2 minutes all the way up to 10 minutes. This can be caused by tachysystole, hypotension, an abruption, cord compression or prolapse, or even vagal stimulation. So 2 to 10 minutes, a drop of at least 15. Our next type of deceleration is an early deceleration. An early deceleration is due to fetal head compression, which causes an increase in the intracranial pressure. This is a normal finding. Okay, this is okay. to have this early deceleration. So when you're looking at this fetal heart strip, you'll see that we have a baseline, and then when the contraction starts, that fetal head is starting to get compressed, getting pushed down lower into the pelvis. And once that contraction meets its strongest point, we also have the lowest point of our deceleration. That lowest point of our decel is called our nadir. So your nadir occurs at the peak of the contraction, and then it goes away again. So think of it as mirroring a mirror image of the contraction. No interventions are needed for early decelerations. Again, they're normal. She's probably very close to delivering. That fetal head is really getting pushed down lower. So you could check her and make sure your room's set up, maybe call the provider and prepare for delivery. Our third type of deceleration is a variable decel. So this, we said it before, we said an acceleration was 15 by 15. A variable is 15 by 15, but the heart rate goes down. It's usually an abrupt drop. So we shut off the blood supply. It's due to umbilical cord compression. So think of the baby squeezing the umbilical cord and it stops all that blood flow. That's why it abruptly goes down. And then it drops, and then think of it as baby like releasing the pressure, and then the heart rate comes back up. This is the most common type of deceleration you're going to see. They're usually shaped like V's, like a variable, a V. And you might also see what are called overshoots or shoulders. So if you look before each of these decelerations and right after them, you'll have which almost looks like an acceleration. The heart rate goes up right before and right after. That's normally seen with your variable decels. Your final deceleration is a late deceleration. Late deceleration, when you're looking at your nadir, so the lowest point again of your decel, it's occurring after the peak of your contraction. Think of later nadir. Okay, later nadir. This is a sign of fetal intolerance to labor. It's concerning. We definitely want to do some sort of interventions to keep this from progressing or getting worse. All right, so that's our late deceleration. Now, if you aren't already confused enough by fetal heart tones, the next thing we're going to look at is what's called fetal variability. And this is the fluctuation in your baseline heart rate that are irregular in amplitude and frequency. So there's 4 different types of variability. Absent variability. This means there's no fluctuation in your baseline. So if we're 140 for our baseline, every single fetal heart rate is 140. It's a straight line on there. That is not good. That's a sign of, fetal intolerance. We're not doing great here. Minimal is where there's a little bit of fluctuation, but it's less than 5 beats per minute. So maybe like a little squiggly line. Again, we're concerned for this one. Moderate variability is where it's 6 to 25 beats. This is awesome. If we have moderate variability, we can be assured that our baby is well oxygenated. Okay, so we love to see moderate variability. And then the last one is marked. And this is another concerning one. This is where it's greater than 25 beats. So it's very big fluctuations from one heartbeat. Like you might have 160, for one heartbeat, and then you're down to 130, then 155, then, 130 again, all over the place. Some causes of minimal or absent variability can be hypotension, cord compression, tachysystole, drugs. Maybe your fetus is in a sleep pattern or premature. A special type of fetal heart rate tracing that's pretty rare but very serious. It's called sinusoidal. And you'll see that on here, it's smooth wave-like formations of the fetal heart rate. This makes it an automatic category 3 tracing, which we'll talk about here soon. This is most likely due to fetal anemia. So maybe we had an abruption or a previa or something where baby has bled out. And this is a stat C-section in this case. to try and save your baby. So this little flow sheet here kind of tells you, okay, you assessed your tracing, what category are you? We're category 1, great, routine management, keep going with what we're doing. Category 3, we're going to prepare for delivery, okay, so by calling the provider, possibly a stat C-section, and perform some intrauterine resuscitative measures, which we'll talk about on the next slide. Category 2, okay, it's kind of broken down like, do we have moderate variability? Because that's what we would love to see. Great. All right, we're continuing in kind of in a good direction. Let's do a couple more interventions, see if we can get this baby to perk up to category 1. And then if there's absent or minimal variability, you know, we're still doing our intrauterine resuscitative measures, but we're just kind of keeping our provider in the loop a little bit more. So what are intrauterine resuscitation measures? Once you look at all those different things of a fetal heart rate, we now need to categorize our fetal heart rate. The NICHD, National Institute of something, came up with these different categories, different terminology, so that everyone refers to fetal heart tones as the same thing. So we have category 1, 2, and 3. And you'll see that category 1 is green, 2 is yellow, 3 is red. Well, green means go, we're good, we're awesome, right? So category 1, you need to have all of the following. You need to have moderate variability. Your baseline rate has to be normal between 110 and 160. We can have no late or variable decels. Early decels are the only type of decelerations we can have in a category 1. And accelerations are they don't have to be present, but they can be. That's a category 1. You have good normal acid-base status, awesome healthy baby. Now let's go to the other end. Let's go to the abnormal category 3. I recommend learning what category 1 is and category 3, and if it doesn't meet either of those, then it's a category 2. Okay, so category 3, you have to have absent variability with any of the following, either recurrent late decels, recurrent variable decels, or a bradycardic. So any of those things that have to go together, or you have that sinusoidal pattern, that strip I just showed you. Category 3s, those strips need to be reported right away to your provider because that has an abnormal acid-base status of your fetus and it's not good. Everything else is a category 2, okay? We won't go to all of them. Category 2, you can't say you have a healthy baby and you can't say you don't. It's indeterminate. You don't quite know what's going on, and we need to do some sort of interventions to help this baby out. So let's look at those interventions. Well, depending on what the causes for our heart tone issues will determine what interventions we're going to do. Ask any nurse something that they remember about OB, even if they don't work in the OB field. Something that they will tell you is veal chop. Okay, so veal chop, and we've added on mine to this, is a little mnemonic to help you remember your fetal heart tone. It's like a pattern that you see, what the cause is, and what we're going to do for management of it. So if you start with V, that stands for variable deceleration. It's due to cord compression, and what we're going to do is we're going to reposition our mom. Okay. E stands for early deceleration, which is due to head compression, and we're going to identify her labor progress because she's probably pretty close to complete, ready to deliver. A is an acceleration, and those are A-OK. No interventions are needed. And then your L is for late decelerations, and this is due to an insufficient placenta, and we need to execute some interventions. We need to figure out how to increase the amount of blood and oxygenation we're getting to our baby. What are these interventions we're going to do? Well, another little acronym is POOF. We're going to change mom's position. We're going to shut that oxytocin off. We're going to give her oxygen, and we're going to give her an IV fluid bolus. Interventions we can do. The first one listed here is an amnio infusion. So what does this do? This infuses fluid back into the amniotic cavity. So think of your decels. Which one of those could benefit from having fluid back in there? Well, I'll tell you which one. The variable decel, because we're doing that cord compression. Maybe if we put a little bit more fluid around that cord, it would not be compressed as much. So an amnio infusion is used for variable decelerations. We can also give terbutaline to stop the contractions. So just like tachysystole, we can give terbutaline. We can also do it if the contractions are causing decelerations. Check mom's vitals. Is she hypotensive? If so, treat that. Check her cervix. Is she dilating really, really fast? And that's why we're having these decelerations. Reduce mom's pain and anxiety. Alter pushing techniques. So if we get to complete and we're in stage 2 of labor and now we're having decels when she pushes, you know what? Let's push every other contraction. And also prepare for a C-section. If we can't get this baby to shape up, it might be a better outcome for it to deliver via C-section. For much the induction versus augmentation, because we're going to do that in skills lab, so I'm just going to go through really fast here. Induction is when we're stimulating contractions to initiate labor, where augmentation is she's already started labor, but her contractions aren't strong enough or frequent enough, so we give some medications to help with that. There's elective reasons to have an induction and medical, and there's a couple different ways to initiate labor. Before inducing someone, we need to figure out what her Bishop score is. The Bishop score tells us how favorable her cervix is. So we're going to check her. We're going to see how dilated she is, how effaced, what station that fetus is at, what's the consistency of the cervix, and where is that cervix located. And she's going to get points for all this. What we're looking for is 6 or less. Okay, so we're under 6. That's an unfavorable cervix, and she needs to have some sort of cervical ripening. They say 8 or plus is favorable. Okay, so what happens to 7, right? Because we see 6 or less and 8 or plus. 7, it's kind of in the middle, but most of the time with 7, they'll say it's a favorable cervix. If her cervix needs to be ripened, so we have that Bishop score of 6 or less, we can do a mechanical ripening. We have a laminaria or a balloon catheter. Again, we'll show you these and talk about them in skills lab. But there's a higher infection risk for this. It can cause rupture of membranes, and it stays in place for about 6 to 12 hours. But what it does is it helps that cervix ripen, maybe dilate a little bit more, get effaced a little bit more. The 2 medications that are used for cervical ripening are dinoprostin and misoprostol. These are medications that get placed by the cervix to help kind of soften and ripen that cervix. There are risks though. Tachysystole can occur and uterine rupture. So these are not to be used in patients with a history of a uterine scar, like a C-section or anything like that. If the patient has a favorable cervix or she is a candidate that cannot receive like the misoprostol or the dinoprostin, then she gets started on oxytocin. This is our big gun medication. This is given through the IV. We started off at a very low dose and slowly titrate it up until we start getting her into a good contraction pattern. The goal is to get her dilating 1 centimeter an hour once she's in active labor, and then you can shut off the oxytocin. You need to do continuous fetal heart monitoring with this medication, deliver via pump. A lot of places have you double or cosign when you start this. It can lead to tachysystole, failed induction, water intoxication, and just fetal heart rate issues. The last thing that can be used to help either augment or to induce a patient is AROM, or artificial rupture of membranes, or amniotomy. This is where you're taking the hook and you're breaking the bag of water. Before this gets done, that fetal head must be engaged, meaning that when you go and check her cervix and you push up on the fetal head, it's not ballotable. It doesn't float away on you. It stays there. An immediate risk of this, though, once her water breaks, is that the cord can come out or come down below that fetus or prolapsed cord. And then once her water is broke later on, she's at a higher risk of developing an infection. Okay, this concludes everything for next week.